Good morning, everyone. Good morning, chairpersons. First of all, I would like to thank Professor Berger and his organizing committee for their very kind invitation for me to be back in Berlin at the Lange Symposium. It's always a delight for me and my husband, actually, to be back in Berlin and meet up with a lot of old friends. Well, old in the sense that I've got gray hair now. Adri and I communicated just before coming here as to what exactly we're going to cover in terms of, well, she's talking about developmental anatomy, and that was a brilliant talk, and I find it very hard to sort of try and do a good job after that brilliant talk, but I'll try my best. So what I'm going to talk about, hearts with intact ventricular septum, starting with these, and then hearts with ventricular septal defect, and of course, when you got atresia, where is the pulmonary blood flow coming from? In terms of pulmonary atresia with intact septum first, the chamber connections are almost always concordant atrioventricular and concordant ventricular arterial connections, and very rarely you have other combinations, for example, involving complete transposition or corrected transposition. Then the physiology, of course, is much more complicated. Not to say that without these other variants, the physiology is not complicated enough. But in terms of consideration, then, we look at the nature of atresia. What if you want to sort of do interventions on these things? What's the nature of atresia? And then the associated malformations. Well, in pulmonary atresia with intact septum, in the vast majority of cases, the lungs are supplied via the ductus arteriosus. So it's, in other words, very well a duct-dependent circulation. But in terms of the morphologic nature of atresia, you can have basically an imperforate pulmonary valve, or no valvular tissue at all, blind-ending muscular outflow tract, or even absence of a ventricular arterial connection. So an example here, right ventricle, look at that hole leading up to the pulmonary trunk. And we got here a sort of dome formation with some sort of formation of three rudiments of the peripheries of the sinuses, so to speak, the commissures, but really an imperforate valve here, but albeit dome-shaped with very tiny little sinuses. In this example, I've cut through that dome valve just to show you more nicely the patent outflow tract, albeit a narrow one, leading up to that dome, and tiny little sinuses. So I think our interventional cardiologist colleagues in this room must be itching to get their hands on this sort of case. It's quite a nice outflow leading up to that dome. What about this one? A BT shunt, the surgeon's been late, too bad for the interventional cardiologist. But there's a reason, because looking down here, it's tiny. That pulmonary trunk is tiny. What about inside? Tiny right ventricle, and you don't see any aperture, do you? No hole, no tunnel leading up to the underside of that pulmonary trunk. Very thick right ventricular wall. Already we see some of these sinusoids in this particular specimen. Let's look at it again from the outside. You see? Blind, totally blind. The patency via the duct, left pulmonary artery, right pulmonary artery is bifurcation, a narrow funneling down of this pulmonary trunk to totally blind structure. By the way, a meandering arterial duct, which is quite typical, isn't it? Try stenting that. So the nature of atresia then, we can have an imperforate valve. Muscular atresia tends to have this sort of formation. No dome membrane at all, tiny little sinuses, blind end. The associated malformation is very important when approaching and trying to decide how to manage these patients. Abnormal ventricular cavity, abnormal tricuspid valve, and Adri has already highlighted coronary anomalies. The cavity size is a spectrum, from tiny to dilated, and this four-chamber cut shows for very nice to illustrate for the fetal cardiologists or doing fetal screening, this disproportion between the left and right side heart ventricular sizes. Left ventricle forms the apex, the right ventricle hardly gets towards the apex. And there is the way of interpreting the size of the right ventricle in terms of wall hypertrophy, overgrowth of cavity by wall hypertrophy, in terms of 3 types, I think. The tripartite, bipartite approach, the apical component, apical and outlet components with bipartite. If you only got an apical component that is hypertrophied, then you can have both inlet and outlet components present. So let's look at an example here. Tiny right ventricle, no apex, overgrowth of muscle, no cavity there at all, outlet also obliterated. So unipartite, isn't it? Just the inlet portion present. And this one, again, apical overgrowth, some outlet overgrowth. There's not actually a nice tunnel leading to the underside of here. There's some muscular interruption between the cavity and where you want to get to, which is this patent pulmonary trunk. Again, a meandering ductus providing the flow to the lungs. In this example, quite a nice small pulmonary trunk, rather, a valve there. We see a membrane, but apex completely obliterated. There is a tunnel leading up to the underside of that valve membrane. That was an illusion. There was actually an apical component present, but because there was like a kind of muscle shelf here, we couldn't, in the beginning, see that apical component. Let's look at this again. So pulmonary trunk, not very small, okay, imperfect valve, but you look at it casually, it's only got inlet and outlet. And that's because there's a muscle bar here that I just cut through, and you can actually see the apical component at the bottom. Now, tricuspid valve is also involved. It's often dysplastic, thickened leaflets and chordae, sometimes road edges, but may show Epstein malformation in some cases, or may even be absent, so-called unguarded tricuspid orifice. Now, this one has a good-sized right ventricle. It is pulmonary atresia. If you look carefully, the valve leaflets are formed, actually, but they don't open. Tricuspid valve is very dysplastic, cauliflower-like. There's a large fossa ovale defect. But the problem in this heart, I think, is massive tricuspid valve regurgitation, dilatation of the right atrium. And we go back up here. I'm going to show you the, look at the pulmonary valve. It's not patent, but we see very well developed leaflets, and the leaflets are joined together, fused together along the margins. So there's a patent ductus arteriosus. So this suggests to me it's a very late stage of development of pulmonary atresia because the pulmonary valve leaflets are very well formed, albeit you can't open them because they're fused together. So is this a case of acquired pulmonary atresia? Well, I can't tell you because I don't have the clinical history of this case. This is another one with a huge right atrium. Right ventricle, it's kind of even parachute-looking tricuspid valve with one dominant papillary muscle. Again, bottom of that pulmonary valve looks like it's very well formed with outflow tract. Huge dilatation, wall-to-wall heart. And this is definitely a very dilated right atrium, isn't it? Again, a fossa ovale defect, very thin-walled, atrialized portion of the right ventricle. No inferior anterior superior leaflet is this one here, sail-like, no septal leaflet, the outflow to the underside of the pulmonary valve. Very nicely formed pulmonary valve, isn't it? Perfect. But doesn't open. So again, a patent ductus is this an acquired pulmonary atresia in association with Epstein malformation. Associated malformation, atrial septal defect, very common. Coronary arterial malformation is very important for the clinicians. Anomalous origin, sinusoids, atretic segments. So some examples showing here. This one has sinusoids. Okay, it's right ventricle. Look at this sinusoid, but it is making a connection, a fistulous connection with the right coronary artery here. Quite a big one too. So you do often find with these coronary connections that you have intimal hyperplasia. Example here, showing atresia of a coronary artery. So we look up and close up here. The right coronary artery orifice is blind. This tiny little strand-like right coronary artery, very white walls. We tend to find these when they have coronary problems, and very small lumen. But here is the fistulous communication. The probe is going into the left anterior descending, and it's coming out into the right ventricle. So the right ventricle, left anterior descending coronary fistula, and this left anterior descending diving intramyocardially before emerging here. And again, very white coloration on the coronary walls. The fistulous communication most frequently found in hearts with small right ventricular muscle-bound cavities. You may have atretic or stenotic coronary arteries. There are cases I've seen with intimal obliteration of the lumen, as well as anomalous origin of coronary arteries. In this case, we have both coronaries coming from the pulmonary trunk. So tapering down here, feeding the coronaries, but no connection with the right ventricle at all. So morphologic spectrum, really just listed here. I'm sure you all know these very well. And the next part of my talk is concerning hearts, pulmonary atresia with ventricular septal defect. In this case, we've got quite a good sized pulmonary trunk, the ductus here, but ending blindly. Look into the right ventricle. We see the ventricular septal defect, but we don't see that outflow tract to the underside of this blind ending pulmonary trunk. So this one has muscular atresia. The supply in this heart was via a ductus arteriosus. We just come back up here. That's the ductus arteriosus. This example, tiny little strand-like pulmonary arteries. This is a systemic pulmonary collateral coming from the left subclavian, going alongside into the lungs, and turning around, descending aorta, a right-sided aortic arch, of course. See the systemic pulmonary collateral arteries going to the right lung and going behind the esophagus, this esophagus, going to the left lung as well. So this sort of situation can be very complex in terms of supply to the lungs. We look inside, it has a ventricular septal defect, it's pulmonary atresia, no outflow to this strand-like pulmonary trunk. Another example, again small, seagull-shaped pulmonary arteries. Inside, a large aorta, but no outflow to the pulmonary. Turn around to the right side. Again, an example of a right aortic arch. That's ascending aorta, left pulmonary artery, pulmonary trunk. Right pulmonary artery, see passing in front of the right main stem bronchus. But something is connecting here, isn't it? See? Something is connecting with the right pulmonary artery. Turn around to the back, to the descending aorta. What is connecting to the right pulmonary artery? Systemic to pulmonary collateral artery, going rightward, sort of making a loop around the right main bronchus. So anastomosis between the systemic to pulmonary collateral arteries and the native pulmonary arteries. But there can be variations. Sometimes you can have only the lung supplied exclusively by collateral arteries. You may have absent central pulmonary arteries as well. So the chart here just summarizing the variations in pulmonary supply. You may have unilateral, you may even have bilateral ductus arteriosus. You may have this situation where one lung is supplied, is connected to the native pulmonary artery, the other lung is via another situation where there's a duct going rightward. Or you may have combinations with systemic to pulmonary collateral arteries and other forms of supply via aortopulmonary window, fifth arch, coronary pulmonary fistula even. So systemic to pulmonary collateral arteries, or MAPCARs, we call them systemic pulmonary collateral arteries because they are not only coming from the aorta. As you've seen one of the cases coming off from one of the arterial branches coming from the aorta, like the subclavian. But systemic pulmonary collateral arteries do coexist with intrapericardial pulmonary arteries, giving a dual supply. So I've colored up blue the native pulmonary artery and then systemic pulmonary collateral arteries in red. But as Adri pointed out, systemic pulmonary collateral arteries hardly ever coexist in the same lung that is supplied through a duct already. But you do have anastomosis, as I've shown you one of these examples. The size of anastomosis can be classified as extrapulmonary, hilar, lobar, and segmental. And if you go beyond that, you really need the microscope. What are these anastomosis? And what's happening at the sites of anastomosis? As we see here, systemic pulmonary collateral joining up with a left pulmonary artery. And this anastomotic site here, often we can find, when we've done the field that we've looked at with histology, some sort of intimal proliferation, giving some kind of narrowing at the site of anastomosis. You see the pulmonary artery, lots of elastic tissue colored more darkly. Systemic pulmonary collateral arteries, more smooth muscle cells. So less dark, you see an internal elastic membrane. Might just catch an external elastic membrane as well. The red is the adventitial fibrous tissue. Then there's always the question, are systemic pulmonary collateral arteries bronchial arteries? Well, I'm not a developmental biologist, so I'm trying to sort of match systemic pulmonary collateral arteries with a pattern that would be seen when we look at four bronchial arteries in the normal heart. And indeed, some of the systemic to pulmonary collateral arteries with anastomosis, as is in this example, do kind of remind us of the courses of bronchial arteries in a normal heart, a normal patient, sort of going around the main airway. This is very typical. And also very typical is in the interlobar position. But this, in this case, is a systemic pulmonary collateral artery in a patient with pulmonary atresia with VSD, and same in this patient. And furthermore, systemic pulmonary collateral arteries follow, in this example, very much the airway. Look at it coming down along the trachea, bifurcating along the major bronchi, and then dividing further into the lobar bronchi system. And I've traced some of these and found that they go to the airways, the segments, the alveoli, and so on and so forth. But little branches do dive into the bronchial wall, supplying nutrients to the bronchi. So maybe some of these are bronchial arteries developed into systemic pulmonary collaterals. And then I thought, well, I better look at some histology. So this is a normal patient. A is taken here, and B is taken here, following a bronchial artery. And here we see smooth muscle cells with some elastic tissue, but here we don't see much elastic tissue at all, but internal elastic lamellae and a bit of external. And this is a histology section I showed you previously with anastomosis between the native pulmonary artery and systemic pulmonary collaterals, and rather similar sort of architecture of that arterial wall of bronchial artery and systemic pulmonary collateral artery. So who am I to say? So in summary then, I think we need to look at the substrate of atresia if you're doing interventional cardiology, hoping to intervene in these patients to improve flow, to develop pulmonary arteries. But when you have pulmonary atresia with VSD, pulmonary blood supply is very important. It's somewhat like these motorway junctions, the anastomosis, etc. So finding your way can be quite challenging. Thank you very much.